All right. Well, thank you everyone for joining the National Board of Public Health Examiners webinar Wednesday. My name is Ashley Mueller, and I'm the Manager of Educational Programs at MBPHE. This year, we're celebrating 15 years of certification at MBPHE. And in that time, we've certified over 12,000 public health professionals. We are excited for you to be here with us today and be part of that community and share in the continuing education. So today's topic is Candida auris, the emerging threat, presented by Douglas Austin. So Douglas is originally from Delaware, and he has worked in public health in the Navy for 10 years. He was a communicable disease epidemiologist for Ventura County, California at the height of the pandemic, and he is currently working at the Mainline Health as an infection preventist. So with that, I'd like to turn it over to Douglas.
Right. Thank you, Ashley. And hello to everyone. I'm really happy to be here today and just to get the time to talk to you a little bit about this pressing issue and just kind of give some awareness to it. So like Ashley said, I'm originally from Delaware. I was in the Navy for just under 10 years. Got to do a whole bunch of different things and got to see a lot of amazing places. Went from Hawaii to Guantanamo Bay to Maryland. I was with the Marines. And so I just got to experience a whole bunch of different things. Once I got out of there, I was in Ventura County for about 8 months as an epidemiologist. And then I transitioned to the local health system out there, Community Memorial, and where I was an infection preventionist. And then about a year ago, I moved back to Pennsylvania just to be closer to family. And now I'm here doing the same job at Mainline Health. So what we're going to be talking about today is something called Candida auris. And I like to say it is an emerging threat because even though it was discovered a little while ago, there is still a host of issues that it presents. So I like to start this off by saying, how scary is this fungus? If you've never heard of this fungus before, or any kind of pathogen, it may seem like really scary and a whole bunch of questions might be like popping into your mind. So when I first gave this presentation, there was a show that had just come out on HBO called The Last of Us, which was like a science fiction horror series about a fungus that took over the world. And after I gave this presentation, some people had asked me if this was the next pandemic. Do you think it was going to be the next COVID, et cetera? And while it's a serious pathogen, I don't think it's anything like that. And then if you haven't seen The Last of Us, I would give it a look if that's your thing. So to start off, what is Candida auris? So this fungus was first identified from a Japanese patient's ear canal in 2009. Auris is actually the Latin word for ear, which gives it its name. Despite the name, though, it can actually cause invasive infections throughout the body. So it's not just limited to the ear. One of the issues with Candida auris is it is often multi-drug resistant. So some strains are resistant to all three available classes of antifungals, or what's known as pan-resistant. Candida auris can also cause outbreaks throughout healthcare facilities. It can be carried on a patient's skin without causing infection, which is what's known as colonization. And this allows spread to others. It can also be difficult to identify with any standard laboratory methods, in terms of colonization. It can be misidentified, so, that's an issue. And then reported mortality rates globally can range anywhere from 30 to 59%. So once it becomes invasive, it can become a very serious problem, and the mortality rates can be very high. So the next question usually is, well, what are the symptoms of having Candida auris? So long story short, it really just depends on where the infection is occurring. So it can cause, like I said before, it can cause infections in different parts of the body, such as the bloodstream, open wounds, or in the ears. The symptoms depend on this location, like I just said. They may be similar to symptoms of an infection caused by bacteria. So you may get something like fever, chills, sweats, very non-specific symptoms. And there really is not a common set of symptoms associated with this infection, unfortunately. So the next big question is, well, how much has it spread then? So as you can see in the upper left, from 2013 to 2016, we had 63 clinical cases that were across the country. And as you can see, there really wasn't that many infections in most states. There's just a smattering of them. But if you go to 2018, it's already reached the West Coast. It's gone to Texas. It's increased in the states that it originally was in. And there was actually a 425% increase in these clinical cases from that time. And then if you move to 2022, you can see that it's prevalent in most states now. And actually from 2018 to 2022, it was a 511% increase. So that's 331 clinical cases to 2,377. So as you can see, it is spreading, and it's not really showing any signs of slowing down. So what are some risk factors for someone who has, or what are some risk factors for someone who may be exposed to Candida auris, or what can cause them to develop it? So people that have recently spent time in hospitals or nursing homes, and they have what's called an invasive device. So this could be like a mechanical vent. It could be a tracheostomy, so like a trach tube or a breathing tube, any kind of feeding tube, or what's called a central venous catheter or a central line. They seem to be at the highest risk for C. auris infection. So anybody that has an invasive line, inserted into them, it kind of just breaches the natural skin barrier and allows this fungus to enter the body. So there's some limited data that suggests that the risk factors for Candida auris infections are generally like risk factors for other types of Candida infections. So I mean, this can include anything from like having recent surgery, having diabetes, or just being recently treated with broad spectrum antibiotics or antifungals. So moving on a little bit more to transmission, how transmissible is C. auris? So this was a study done a few years ago. It was from Chicago Department of Health in conjunction with the NIH. And what it shows is a ventilator-supported skilled nursing facility, or a SNF. And what they did was they initially screened all the residents on the floor for Candida auris. And they wanted to track to see how much the prevalence increased over time. So initially we had, like I said, 30 rooms. And when they did the 69 screens, they only found that one person was positive. So this was a 1.5 prevalence rate. So moving from March to January of 2018, we went from 1 now to 29. And so that's a 1.5% prevalence rate up to 43% now, as denoted by these purple X's throughout the unit. And then once more, 10 months afterwards, it is now at 71% throughout the facility. But to further complicate this issue, and adds to the complexity, 2/3 of these patients that had Candida auris were co-infected with something called a CPO, or it's a carbapenemase producing organism, which is a multi-drug resistant organism. So what this does, the problem it creates in a long-term care facility is when someone has a different organism, it makes it very difficult to cohort them with people with similar infections. So as you can see, there's different symbols for the legend down there, and this facility tried their best to group like infections together, but obviously it's very difficult with the variety of infections that were going. And this is just a graph overall of what happened. So as you can see, from January to October of 2018, we started off with 43% prevalence in January. And by the time it was October, it went up to 71. The CPO, or carbapenemase producing organisms, was 42% in January and went up to 62. And then the co-colonization, so having both, was 27% in the beginning and went all the way up to 49. So quite an increase in a short amount of time. So Candida auris and infection prevention. So as an infection preventionist here at Mainline, one of the main questions people would ask is, well, what can we do about Candida auris? So luckily, there are some things that we can do. The first being is to have visitors and staff adhere to strict hand hygiene guidelines and regimens. So what does that really mean? It means when you go inside of a room, when you go outside of a room, if you get done performing a procedure on someone, And make sure that you're washing your hands with soap and water or an alcohol-based sanitizer for at least 20 seconds, and making sure that you do that all the time. Also, it's important to have a rigorous surveillance system implemented to ensure that you capture these high-risk individuals coming into your facility. And I'll actually discuss more later on about what we're doing here at Mainline to do that. Also, we want to adhere to what's called contact isolation precautions. And now, if someone is suspected of having Candida auris or they're being ruled out for Candida auris, they need to be placed on contact precautions. And as you can see on the right here, this is the sign that would be displayed outside that patient's door. It just reminds someone to clean their hands, make sure they put gloves before they go in the room, and discard these gloves before exiting the room, in addition to a gown, and then washing their hands, of course. Additionally, they want to use dedicated or disposable equipment for that room and clean and disinfect anything that's reusable before they use it on another person. Also, once that patient is discharged, they want to make sure that there is a thorough cleaning and disinfection of that patient environment. So if you actually go to the EPA or the Environmental Protection Agency website, you can look up their they're listed by different letters. So P would be a product specifically for Candida auris, and list K would be products listed for C. diff, and you'd be able to use either or for Candida auris. Also, the last big thing would be communication when patient is transferred to another facility. If we have someone that's being ruled out or being positive and they're being transferred off to a SNF, it's very important that we get in contact with that receiving facility and let them know so they can continue these isolation procedures when they get there. So with all that bad stuff that I just said, I do want to say it's not all doom and gloom. There are some positive outlooks to Candida auris. With the first one being that, in general, Candida auris is not a threat to healthy people. So this includes healthcare workers. So Candida auris mostly affects patients that have severe underlying medical conditions or something that requires complex care. Like we had mentioned before, this is usually an issue for someone who has multiple invasive devices, such as a PICC line, central line, or mechanical ventilation or a trach. And by practicing good hand hygiene, adhering to your isolation precautions that we just talked about, having a surveillance system in place, you can actually limit the spread of Candida auris in the healthcare setting. So with all that being said, what are we doing here at Mainline Health? So Mainline Health is a hospital system out here in Pennsylvania, and I am at the Bryn Mawr, Pennsylvania location. So I'm going to talk a little bit about what we do here for that. So the Bryn Mawr Health Infection Prevention Team, we have a list that we screen each day that kind of rules out patients that meet this criteria for Candida auris. And what we do with that list is we pull it from our electronic medical record, which is known as EPIC. And we have a set of criteria that we can put in that if someone meets, they'll flag in our system. And then we can know to investigate that patient further to see if they warrant being placed on contact precautions and being screened for Candida auris. Once they're identified, we also notify the treatment team. And again, like I said, they place them on contact precautions. And then we tell them that we're going to bring a swab down to the unit for collection. Now, the way that this person is screened for colonization is it's a swab that was given to us by the Pennsylvania Department of Health. And the swab is put under the patient's armpits and groin, because that's how we screen here for colonization. The swab is then shipped off to what's called the Antimicrobial Resistance Laboratory Network, or the ARLN, and there's one in Baltimore, Maryland. It's sent there via FedEx to be tested for colonization. And then we have access to a state lab portal that was given to us. We check it daily for the results. It typically takes anywhere from 3 to 4 business days for those results to come back. So going over these screening results here, we can see that patients that meet this criteria. So at Bryn Mawr Health, all the way on the left, we can see that we have 53 that we screened initially. And of the 53 that we screened initially, 3 of them were positive. So for a positivity rate of 5.66%. And then to the right, that's our sister campus, LMC, or Lankenau Medical Campus. They had 81 screens with 7 positives for 8.64. So the total for these two facilities, we had 134 with 10 being positive for a total percent of 7.46. So what are some challenges that we faced? One of the biggest ones was laboratory capacity, and the testing remains limited. So again, this is testing that is not done on site at Mainline. We're kind of at the mercy of the Maryland State Lab. So when we send off this specimen to the Maryland State Lab, a lot of times there can be delays in the patient result, being processed. Specifically, if we're not really supposed to send the specimen on Fridays due to the package not being received until that Monday. And this is obviously problematic because it can hold up a patient's discharge. If a receiving facility finds out that the patient is being ruled out for Candida auris, a lot of times they won't accept that patient into their facility until they get those results. So this has been an ongoing issue, and we've been working with the Maryland State Lab to try to streamline those results to get them back faster. Also, pulling the LTAC or the long-term care acute name information from Epic to facilitate this identification has been kind of problematic. There was no way to really set a set of criteria in Epic to screen for these high-risk facilities that patients may have come from. So what we've been doing to really counter that is just provide a lot of education to the emergency department, as well as the units throughout the hospital, just to let them know essentially that, hey, if someone comes from one of these facilities with this set of criteria, you need to reach out to us immediately, and then we can take the next steps. So also, what are some achievements that we've had? So people at risk of CRS, initially before the system was in place, it was very difficult to identify them. But now with having this Epic list put into place, we're able to isolate them and place them on contact isolation in a very short amount of time. So if this person ends up having Candida auris, we reduce the risk of spread to other patients and staff members. Communication with these transferring facilities has improved as well as we've done more and more screenings. So before, where they would say, hey, what is Candida auris? Now they kind of understand the process, and they know they just have to wait maybe a few more days for those results to come back. We've also standardized our forms for transfer. Again, like I talked about, just having that education piece within the hospital and these transferring facilities. And we've utilized those across both campuses. Also having a multi-step cleaning process, we've added that to Epic to identify anyone at risk. So what happens is if someone who has Candida auris or someone who's been ruled out for it, if they become discharged, it actually flags our environmental service staff throughout the hospital, and it'll allow them to do a terminal clean of the room and do what's called true D disinfection of discharge, which is cleaning the room with ultraviolet light to assist in eliminating any residual fungus that may be left. Also, we've actually improved our education. We provided at several different meetings to ensure a wide audience. So this could be like our clinical operations, which is involves staff at every level in our hospital. We have a group here called the Infection Prevention Liaisons, which is members of staff throughout the hospital that take a strong interest in infection prevention. Critical care fellowships, and also we have infection prevention partnerships that share education and swabbing directions when a screening patient is identified on unit for the first time. And then these are just some resources out there. For those that may not be familiar with Candida auris, there's tons and tons of info out there now. Not only could you talk to your local health department, but additionally you could have sources at the state, the CDC. You could reach out to the infection prevention agency known as APIC, which is the Association of Professionals in Infection Control and Epidemiology, for guidance. And all these resources would really be able to help you set up a plan of controlling and limiting the spread throughout the facility. Now, I know I ran through that a little quickly, but wanted to see if there was, I want to leave a lot of time for questions about this.
Yeah. So it looks like we have a couple questions.
Sure.
The first question I see is, does hand washing and hand sanitizing have the same efficacy?
So in some situations, it's better to use an alcohol sanitizer versus a hand washing thing. Typically, you would want to use an alcohol-based sanitizer though, versus hand washing. There's only certain situations where that wouldn't apply. So in the cases of C. diff, for instance, or anything that produces spores, you would actually want to use soap and water because that would eliminate the spores instead of the alcohol. But in the terms of Candida auris, you actually can just use sanitizer. And they'll be just as good as soap and water.
Great. The next question is, in the transmission study, did everyone in the SNF have a central line or invasive device?
That's a really good question. I would have to look back into the study to see if that was the case. Since it was a ventilator equipped facility, I would assume that most of those patients there were on vents or had some kind of central device placed into them. But again, I would have to go back and look at the article to confirm it.
What happens when there is a positive colonization result?
Yeah, that's a really good question. So it all honestly, it depends. So if, let's just say we have a patient that comes in, they're immediately identified and they're put on, contact isolation as soon as they come in. They turn out to be CRS positive. If they've really been nowhere else in the hospital and they were immediately put on, there might not be much to do once you notify the state. However, if this person has been there for a couple of days, they've been through multiple units, there's been a whole bunch of staff that have been there, your work may be more involved. So for instance, we've had to do what's called a point prevalence testing or point prevalence survey, because before we had this surveillance system in place, we actually had this happen to us. We had called the Pennsylvania Department of Health, and they decided that we needed to test an entire floor for Candida auris. So those several patients, I believe it was the intensive care unit. And I believe they wanted to do more, but then they ended up, rescinding that part. So we did end up having to screen the whole floor. It could be just as intense at a bigger facility if it were to happen at your facility. So that's why I think it's critical to have that surveillance system in place and to put those people in contact isolation as soon as possible.
Right. When you're screening for Candida auris and it's still not confirmed, what infection status do you place them in?
So in EPIC, we actually have two different options. We have a Candida auris screening option. So just to let people know that they're being screened currently and that, they'll be on contact precautions, but it leaves room for notes too. So I like to usually fill those out with where we're at in the process. So, hey, I've swabbed this person, I've sent it down to get shipped off, we're just awaiting results. But, they'll have to remain on contact precautions so that comes back. Now, if they come back positive, we actually have a different infection banner that says Candida auris positive. And if they come back positive, our policy and most likely other policies at other facilities too, is they have to remain on contact precautions for life. Now, the reason for that is we don't really know that if you can truly decolonize someone with Candida auris. And that's why there's not enough data to support that. So that's why they just say you have to leave these people on for lifelong contact precautions.
Right. We do have one person who made a comment that said, I've had my fair share of PPS at my organization. It's not fun.
Yeah, no, it's very intense. It involves quite a bit of work, and just like coordinating with the floor and the state and trying to just make sure we get everyone swabbed.
Yeah.
One thing I did want to mention too is a lot of people have asked, what's really happened with the research efforts in Candida auris. So this is like a disease that's come out in 2009. There's still limited data in some areas. So, what are we really doing about it? And the CDC is doing quite a bit of research on this, but there's still some like key questions that they want to answer. And one of them is, we want to find out, why is Candida auris resistant to antifungal medicines? And that's a really good question. We're also trying to find out, why did Candida auris start causing infection only in recent years? For all we know, this could have been around for a very long time, but why all of a sudden is it causing infections? And then lastly, where did Candida auris originally come from? And why has it appeared in many regions of the world at the same time? So yeah, these are all like really good questions. And I think it's fascinating to see that this research is being done. It'll be interesting to see what results they come up with.
Yeah, definitely. We do have another question that's about the test results. So once
Sure.
you send it in the test results, how long does it take to get those test results back?
So again, according to our ARLN lab, it's usually about 3 to 4 business days. However, there can be delays, if we typically try not to collect a specimen on a Friday because again, this won't get processed at all until Monday. There could be some kind of delay with the shipment. So unfortunately, this can cause patients to have to stay there a little bit longer at the hospital before they can be discharged. But typically it's 3 to 4 business days.
Okay. Then do you provide your clinicians with best practices or recommendation products for disinfections of their stethoscopes between patients?
Yeah, so I mean, we have policies throughout the system for cleaning and disinfection of all equipment. So not just for Candida auris, but for anything. So if there's any kind of question about, hey, I have this piece of medical equipment, what should I use? We have a policy we can refer to, and they'll point us in the right direction for which product to use.
Great. And then one more question here is
Sure.
in the long-term care setting, would someone colonized with Candida auris be appropriate to be on enhanced barrier precautions versus contact precautions?
Really, I think just having them on contact precautions would be enough. You know, um, it's a pathogen that is spread primarily in the environment. So, it can be on surfaces, and really all we require is having that contact barrier. So it's just gloves, a gown, and making sure that you're always washing your hands with either an alcohol-based sanitizer or soap and water.
Great. Um, is there a vaccine for Candida auris?
That's an interesting question. So currently there is no vaccine for Candida auris. It has been talked about. And I believe there was one company out in California that was doing some research on it. And I think they were seeing some promising results in mice. But of course, this would have to be taken to human trials before anything, would become concrete.
Great. Um, so if we have any other questions, please be sure to post them in the chat. I do see one question about the slides. So I will post a recording. So you will have that available to you. Most likely it'll take me about a day. And I just need to get it up there and, all the logistical parts. But if we don't have any further questions, then I will definitely, oh, we do have one more question here then, about how many cases of positive patients have symptomatic or damaging infections.
So we try to delineate between colonization versus a clinical case. So as I believe it was the one slide I presented, it showed, let me see if I can go back to it real quick. In 2022 across the country, we had 2,377 clinical cases. So that means Candida auris became invasive at some point. So these patients were colonized and then it got into like their bloodstream or an open wound or what have you. As for colonization, I don't have any data readily available for that, but I do believe it does exist. I would check like the CDC or maybe even like your state website to find that.
Okay. Then how often is Candida auris spread by glove misuse or lack of following cleaning product instructions?
I mean, I can't give like a how frequently, but if there's any kind of breakdown in disinfection or just doffing your PPE improperly, that's when the chance of spreading this pathogen occurs. So, for instance, you could take off your gloves and not wash your hands properly. You could touch an environmental surface and then go over and touch the patient, or a patient could touch something in the environment that wasn't cleaned properly. They could have the pathogen on there and they could touch an entry point around one of their invasive devices. And this could cause, entry for that pathogen to the person.
Great. Just when we thought we were out of questions, we're getting a bunch
Ah,
more.
it's
So,
okay. It's
uh,
okay.
Could you explain the difference between colonization and asymptomatic infection?
Sure. So colonization just means like there's the presence of you having it, but it's not actively causing an infection in your body. So basically you feel fine, but you're still carrying the bug, and you have the potential to spread it to others. Versus where you have an active infection, that means it's invaded some part of your system and you are sick from it. Now, at any point, someone who has colonization of Candida auris, they can have an active infection, but it's more likely to happen when, like we had talked about before, with the risk factors of having these invasive devices. So central lines, recent surgery, having being intubated or having a trach or anything like that.
Great. So the next question is, have you seen Candida auris more in vent trach, LTACs in your area?
Yeah, so specifically, the Department of Health, they kind of did this research of the high-risk facilities in our area, and they sent us a list of the long-term care facilities that would most likely be the ones to give us patients that would be at the highest risk of having Candida auris. And some of them are ventilator supported ones, but then again, some of them are just regular LTACs. But I would say the majority of them are ventilator supported.
Yeah. We do have a comment here that says it seems like encouraging patient hand hygiene might be helpful IP practice to stem the spread of Candida auris.
Absolutely. And it's not just Candida auris. It's the number one way to prevent any infection. But if there's any other infection preventionists on the line, they know it's very hard to convince people to continually do this at all times, when necessary.
Yeah, definitely. All right. Do we have any more questions? I'll give you guys a couple more minutes. I will say while we're waiting, just for final questions,
Sure.
if you are interested in presenting and being a presenter for our CPH webinars, we are looking for presenters always. So when I send out a Zoom survey tomorrow, just for feedback on this question or this webinar, there is also another link that if you're interested in presenting, you can give us an idea of a presentation you'd be interested in sharing with the group. So with that said, I don't see any new questions coming in, but if anything comes up, feel free to contact me. You can do that either at the info@mbphe or Ashley Mueller, so A Mueller at mbphe.com. And I will be sure to make sure that the questions get over to Douglas. And so with that, I'd also like to thank Douglas for your time today and sharing the information that you have on Candida auris and the emerging threat and what you've seen yourself. So we hope everyone has enjoyed today, and I hope to see you back next month on March 13th for our next session, which is Science to Advance Social Change via the Punk Rock Ethos, presented by Cynthia Pret-Diaz. So we hope you'll join us next month. And again, thank you all for being here today.
Thanks again for having me, and thanks everybody for coming.